welcome to EuroPCR 2021. My name is Didier Tchetche. I'm interventional cardiologist working in Clinique Pasteur, Toulouse, France.
My name is Lars Sondergaard. I'm an interventional cardiologist based in Copenhagen, Denmark.
So Lars, we're going to have a discussion on how to implement the latest evidence on TAVI pathway optimization, cost effectiveness, and allow different heart teams all around the globe to treat more patients, because we now have to treat more patients. And if we start directly, Lars, I know that you are a high volume center, so you have a lot of experience. So you had to optimize your TAVI pathway just to make sure that you were able to treat more patients, because it's true that we have a broader range of indication for TAVI. Now the guidelines even propose to discuss TAVI for RX stenosis patients, regardless of the risk profile of the patient. So this is going to bring more patients to our institutions, and we need to optimize the TAVI pathway to be able to treat these patients. So how did you achieve that at your institution?
Thank you, Gigi. It's a very important question, how to actually streamline the patient management in order to be able to treat more patients, but of course not without compromising the safety and efficacy of this procedure. And in Copenhagen, we have focused on several things: patient-specific planning, also of course pre-procedural anatomical planning of the procedure itself, simplification, and also what often keeps the patient in hospital after the procedure, reducing the risk of conduction abnormality. So years back, we introduced specialized TVT nurses, and these nurses are seeing all the patients prior to admission to try to screen them for frailty and special needs. And the plan, not only the hospital stay, but also how to discharge this patient after the procedure. And some of the patients is actually elected to be admitted to hospital the same day as the procedure. And when you try to get these patients home very early, often the next day, it's very important to have a close follow-up, calling the patient on the telephone, and also, if needed, see the patient in the outpatient clinic. So we've seen that in the cath lab itself, there's been a significant simplification of the procedure. It used to be set up like open chest procedure, but nowadays it's pretty much the same as a PCI. And one main factor is to switch from general to local anesthesia. So we do not have any anesthetic team in the room. We do not use sedation as a routine. We just had one nurse sitting next to the patient, explaining what's going to happen during the procedure. And this also means that the patient is much more hemodynamic stable during the procedure. And if you have complication, the patient will be aware of that very early, so you recognize complication early on. And not putting the patient into general anesthesia also means that you can bypass the ICU, so the patient can go straight back to the ward. And this, of course, makes it much more flexible to plan and execute these procedures. One major factor which are keeping the patient in hospital after a TAVI procedure is new onset conduction abnormality. We all know there's a close proximity between the conduction system and the AV valve. And if you implant the valve too deep, there's a high risk of conduction abnormality. So that's why everyone tries to implant at a high position, of course, not risking a pop out of the valve. And we've seen this move from a classical LAO projection towards a cusp overlap view. So that's decided on your pre-procedural CT scan to choose the C-arm angulation where the left and the right coronary cusp is overlapping. And the reason to use that is this is often where the two S-curves are crossing. The S-curve, which are telling where is all the aortic cusps aligned, and the other S-curve, where is the delivery system aligned. And where these two S-curves are crossing, this is where you have no parallax on the delivery system and also have the three aortic cusps aligned. This gives a better understanding of how deep or how high are you during the valve implantation. And this projection is almost always in an REO caudal projection. We know that in addition to have the three aortic cusps aligned and no parallax on the delivery system, using an REO caudal projection elongate the left ventricular outflow tract. So this is the ideal implantation to have a high implant without the risk of a pop out. So just to summarize here, the left-right cusp overlap view maintain the basal plane of the aortic cusp and also remove or reduce the parallax of the delivery system and elongate the left ventricular outflow tract. And we just saw the data here from the OptimizePro study, where the objective was also to use the cusp overlap technique. In those 171 patients, including in the beginning, we saw that according to the core lab, the implantation depth was only 3.3 millimeter at the non-coronary cusp, and also the need for new permanent pacemaker was only 8.8%. So this is certainly one way to streamline your TAVI procedure and also to ensure earlier patient discharge.
So thank you very much, Lars. This was crystal clear on how to optimize the TAVI pathway to make sure that we don't compromise the clinical outcomes from the patient, and keeping in mind that we need to avoid complications. And the data from the OptimizePro study and the way you organize your overall TAVI pathways are really impressive. I just wanted to, it reminds me that we did present during this EuroPCR 2021, the cost effectiveness data from the Evolut low risk trial applied to the French healthcare system. And it's quite interesting because there is always that discussion on the cost effectiveness of TAVI when it comes to low risk patient. And so we utilized the data from the Evolut low risk trial with the self-expanding platform. And we compared that with the data, the cost data coming from the French healthcare system. And the main conclusion is that TAVI is cost effective in the French spectrum, in the French healthcare system, and when we consider low risk patients. And there is another very interesting piece of information coming from this analysis, is that the main difference between surgery and TAVI is related to the procedure itself and the rehab. So it tells us that if we do everything, all that we can just to improve the procedural outcomes, as you nicely demonstrated from the data coming from the OptimizePro, we may even make a TAVI more cost effective than it is today. So I'm pretty sure that we are going to face the same type of data if we translate the analysis that we made to other European countries. We've seen that with already a couple of European countries. So we need to work at each institution with all the stakeholders to make sure that everyone makes the effort to promote TAVI, because this is really a very important display window. We have more patients to treat. We need to treat all these patients in a very safe way, but we need to keep in mind that we already have a cost-effective procedure, but it can even be more cost-effective if we spare human resources, if we make sure that we avoid complications, if we early discharge the patients, but still in a safe way. So every component of the heart team, but also the administrators of the hospitals are really important to keep that cost effectiveness correlated to safety of the patient. So that's really one of the key learnings from myself. I'm really glad that in France it's cost effective, but I'm sure that this could be applied to other countries also.
That's great, Tchetche. So streamlining patient management for TAVI not only allow to treat more patients, but also make this therapy more cost effective. And I think we have seen similar data from both Norway and Ireland. So with this, thank you for listening. Hope you're going to enjoy the rest of EuroPCR.
Bye-bye.